Okay, am I back live again? You know, ever since that guy got prosecuted for wearing the mic in the bathroom and saying that he killed all those people, I've become even more paranoid about this. Now it's beyond just whether you can hear the toilet flushing or not. You know, it's a little nervous. So, all right. So, unfortunately, you know, after lunch is the worst time to talk about codes and coding because it's real easy to nod off. So if you see me nodding off here, let me know. So, but we'll try and keep it hopefully somewhat entertaining. All right. So what I want to do is talk a little bit about the code structure and code documentation basics. A lot of this, of those who have done coding, you already know the basics, and they're not that much different in 10, except there's a lot more stuff, right? But the concepts are the same. Touch a little bit on how we deal with clinical documentation. And we know that all the physicians in here today are probably the best documenters in the world because they're all here, but we also know that it's variable, right? And we'll talk a little bit about how we improve that, right? Then we're going to walk through some case studies, and hopefully they'll bring up a bunch of different questions. So hopefully this will be a bit more interactive. I was hoping to have all my tools up so we could actually walk through them. We'll see how much we can do because we had a little problem, technical problem, hooking up to this projector here. But we're going to talk a little bit about that. And if anyone is interested in doing some coding stuff afterwards, if you bring a margarita, I'll stay here and we'll do them together. That's the price. All right. So as I mentioned, we've got this thing, and this is all free stuff, right? You can download everything from the CMS site, all of the tabular index, all the alphabetical index, all of the codes, all of that stuff is out there, plus a whole lot of other stuff. CMS really did a lot to get a lot of information out there. They also put this GEM mapper, as we mentioned, this general equivalency mapper. The problem is that unless you're an IT person, you can't use it. But as I told you, I put this in a tool. We may actually try an example of that just to show you how it gets used. But all this stuff is free. There's a lot of free stuff out there. But it's not terribly user-friendly sometimes. So here we've got, if we look in the alphabetical index under osteoarthritis, you'll see this long, long list goes on for pages of here's the key term, and then there's all these subterms, and they have a dash if it's one level down, two if it's two levels down, et cetera. So I think they could have done better on this, but you can search this with, it's a PDF file, so you can search for words in it and use it to some degree. But here is like the arthritis area. So if we look under osteoarthritis, we'll see for ankle, elbow, generalized, if it's generalized, whether it's erosive, primary, specified, et cetera. The rule is that when you use this index, you can't code from it. You have to go to the tabular index because there's other information at the tabular index, which is the Bible, to get to the right code. So if we go to the tabular index, looks very much like ICD-9. There are these chapters, and they use a terminology chapter. So the codes are at different levels of detail. Chapter is the highest level, and it's got, most of these are driven by body systems, but not always. Obviously, things like neoplasms are independent of body system, pregnancy, et cetera. But this is, and it looks very much like 9, except some of these chapters have changed. So if we look under disease of the musculoskeletal system, where we would find most orthopedic things, well, actually we don't find most orthopedic things there because all the fractures are in chapter 19. Right? So this really relates to musculoskeletal system disorders, things, metabolic disorders, osteoarthritis, a variety of other things, but all the fractures are going to be in chapter 19. But let's just use that example. I'm looking for osteoarthritis. Look at the tabular index. The next level down are what's called blocks. Right? So you go from chapters, down to blocks. And blocks are groups of codes at the 3-character level. Here we have osteoarthritis as a block, and if we look down, here are the 3-character level categories that are in this block called osteoarthritis. Polyosteoarthritis, osteoarthritis of the hip, etc. So I'm kind of working my way down the chain. And if I go to this section, here's the block, osteoarthritis. It includes codes that start with M15 to M19. And if we look at this particular thing here, we know that all of the codes that are in this section follow a same rule. So there's a rule that says that anything that is at a parent level is inherited by all of its children. Right? So anytime I look at some code down here, I have to also go up and see which rules apply. Now besides that, there's another set of documents that are called the coding guidelines that also refer to this. So there's a number of documents that kind of come together. So here I am in osteoarthritis. I run into this thing called excludes 2. I think for those of you 2 years ago we talked about exclude 1 and exclude 2. They're kind of like thing 1 and thing 2. Right? They're very confusing when you're looking at this. Exclude 1 means not coded here, and excludes 2 means not included here. Now, is that really clear? No. I thought it was very confusing. All the coders said, oh, that clarified everything. Well, not for me. All it really means is that if you see excludes 1, you never code these two things together. If it says excludes 2, it says, if present, use an additional code. Now, why they didn't say just use additional code for this, I don't know. But nonetheless, that's all it means. What it says is if I have polyosteoarthritis in any one of these codes here, because this applies to all of them, it includes arthritis at multiple sites, which would make sense. It excludes bilateral involvement of a single joint. You'd look someplace else. So they're just rules that tell you about where to look for those things. You'll also see some information below codes or below different levels, and this simply says these are examples of or terms that might be used instead of. Okay. So there is a set of guidelines about how to use this document, about sort of the rules, but basically this is the Bible you look at. Now we showed this one briefly before. Anything at a parent level, so this is at a category level, S72, the first 3 characters, fracture of the femur, and anything below here applies to everything that starts with S72. So that means that for any of those fractures of the femur, the 2,466 codes that go on for several pages here, for all of those codes, all of these things apply. Example, excludes 1, traumatic amputation of the hip and thigh. I would never code that with fracture of the femur, right? Because I can't have an amputation without fracturing the femur. Right? Wouldn't work. Excludes 2, if I have a fracture of the lower leg or foot or a prosthetic fracture, I would use an additional code because that is not included here. Use additional code. For all of these fractures, I always have to have a 7th character. Now, if you look at the code list, they have all those 7 characters already applied, but if you look in here and you go on to the next pages, you won't see this again, right, because it's at the heading. But you have to know that everything that starts with S72. And general rule of thumb is, for almost all fractures, you have to have one of these 7th characters. As a matter of fact, what I usually do is just pull it out and put it as a little side thing over here, saying all the fractures, these are the ones I'm going to have to use. Now, that isn't true for every single type of fracture, but it's pretty consistent. If I look further down, we'll see S72.8, other fracture of the femur, S72.8X, and X is simply a placeholder. This is not a code. It's a subcategory. This is not a code. It's a subcategory also because it has these things down here that are more detailed. The rule is if you have any children, you are irrelevant, right? Which we all know. I mean, if you have any children, you're, so if there are child codes. Now, sometimes it's not, it's not a matter of detail, it's a matter of do we have things underneath there. So I'm looking under here and saying, you know, these, given that I add the 7th character, right, so there isn't just one code here, there's actually 7, or whatever that list is. Right? There's, I think, 13 codes there because you add a separate character and all those are separate codes. Right? Other fracture of the femur, but it used to be, and even I know here at Regents, because I was doing some work with them, they used to accept what they call short codes. Right? No more. You have to use a valid code. CMS puts out a list and it said here are the codes that, and it's got a little tag, it says valid or invalid, and if it isn't down here at the furthest level, it's called invalid and it won't be accepted. So you always have to make sure you're using the most detailed level code. And most of the edits and rules are built to mark only those that are valid as acceptable. Here we have unspecified fracture of the femur, which of course we would never use because we would never be that vague. Right? But if you did, here's what would apply to that. All right, so let's touch a little bit. My purpose here is not necessarily after lunch to do a real coding workshop. We're going to talk about what some of the factors are because one is I don't think you should ever do coding workshops after lunch. That's just not a good thing to do. But just to get some awareness. Now I think that internally you need to really have some intensive orthopedic coding training, right? Specifically focused on that because it's going to be very different, and that's really sitting down and doing the heads down work. We're going to touch a little bit on that today, but we're not going to cover enough of that. So the coding guidelines, you'll see instructional notations. It says that you, in all of these different areas, the chapter, block, category, subcategory level, there are a variety of notations and they can occur at any level. The rule is whatever is stated up here applies to all the children. Here we have this thing called initial encounter. Now I put that up because this is new. We never had initial encounter in ICD-9. An initial encounter, as we mentioned, can be a bit gray, and when you read the guidelines, it really doesn't clarify it a great deal. It talks about, here we say that the definition, well, we say examples of active treatment. Initial encounter is used when the patient is receiving active treatment for the condition. Well, what is active treatment? We don't really know. So I've gone back and talked with AAPC, AHEMA, the coding guidelines folks. No one has real clarity on this. They said it's a rule of reasonableness. The rule of reasonableness is if that's the first time you've seen the patient independently to evaluate the patient, then it's an initial encounter. If you're seeing them on behalf of someone else in follow-up, it's a subsequent encounter. Same patient, same condition can have multiple initial encounters by different physicians who are seeing them independently for evaluation. Right? That's a general rule to apply. So don't get hung up on this active type treatment because that really is so vague and no one has a consistent answer I've been able to find on that. Subsequent encounter is just anything that's not an initial encounter unless it's a sequela. Right? A sequela meaning they had some problem that they're being followed up for that condition and then that related to that condition, and then that would be marked as a sequela. So there's 3: initial encounter, subsequent encounter, and sequela. Now here's the confusing part. If you have a non-union or malunion, to me, I would think that's a sequela of the problem. No, it's just actually, it's under subsequent encounter. Okay, so those are the 2 exceptions. And don't ask me to explain why they did some of these things, because I don't know. Or you could ask me, I won't have a good answer for you. All right, signs or symptom codes. Now this is an important one. This gets back to what codes do we use? Do we put all the codes in there? What do we use? And we'll give a couple of examples. The general rule is that if the symptom or finding would be normally associated with the condition, don't code it also. Right? So if I see a patient with osteoarthritis of the hip who presents with hip pain, decreased gait, et cetera, I would not code those things. The rule says those are things normally associated with osteoarthritis, so don't be redundant, because we don't want to code all the symptoms. The only time you code a symptom is if you really don't have a diagnosis that it's associated with and you're coding it independently. So signs and symptoms that are associated routinely with the disease process should not be assigned as additional codes unless the little rule down there says code also. Right? But most things you wouldn't code this. Very, very rarely. You'll hardly ever see that exception. And then we have includes and excludes, as we mentioned. Sometimes you'll see this where it says includes. Sometimes you'll see the code where it just has a list of things. They mean exactly the same thing. They're all means, oh, by the way, if you have systemic collagen disease or systemic autoimmune disease or collagen vascular disease, that it's to be coded under this group or category. Or if you have a patient with brachial neuritis, lumbar neuritis, lumbosacral neuritis, thoracic neuritis, radiculitis, code those all to radiculopathy. Right? Now, it's not comprehensive, but what it is if these different terms are used, this is where you code them to. We don't have a separate code for that. And feel free to interrupt anytime. Yes, someone taking me up on that right away. So we need to get a put you to work. Guy back there needs you.
I don't need it. I understand what sequela is. So I understand what sequela isn't. What is it? Can you give me an example?
Yeah, let's say the patient has a fracture of the femur and ends up with myositis ossificans, right? And there's followed up for that condition, then that might be a sequela of, at which time I would also code myositis ossificans, right? So that's a sequela. Now, the only exception is non-unions and malunions. For some reason, those are put in subsequent encounter and not coded as sequela. If every other thing that might be associated with that, then yeah. Yes?
Can the same patient have multiple initial encounters about different problems?
Oh, absolutely.
So, for example, on Monday they have a fractured wrist, and Tuesday they have a carpal tunnel related to that. Is that an initial encounter? Or I guess that'd be a sequela, probably.
You know, if you can code that it's a sequela, but I would also code the carpal tunnel, right? Because if they have a sequela, you also have to code what the sequela was, right? Things like, you know, the patient has a compartment syndrome, something like that. That might be a sequela of treatment, but we would also code the sequela. All right. We already talked about excludes 1 and excludes 2. Excludes 1 means don't code it here. Excludes 2 means other not coded here. You need to use an extra code. Yes, we have a question. I'm going to take over your job here.
So if you had a total knee and they got stiff, so they're now arthrofibrotic, you have to manipulate them. That would be a sequela.
Yes.
And then a month later you see them and they've now resolved their, you know, or 2 months later they've resolved the arthrofibrosis. Is now that where are we in the encounter again?
I wouldn't code it then.
Well, you have to code something. You're seeing them back.
Well, yeah, the
2 months
patient
later.
may be post-op for, there's a code for following a patient after a total, I forget which code it is, but there are codes that are relevant to that. But I don't need to encode that complication code anymore because it doesn't exist anymore. But there are codes that would be appropriate for a patient who is being seen for those types of conditions who now doesn't have that problem anymore. Okay, occasionally you'll run into this code first. Pretty simple. Code this one first. So if I see a patient with a direct infection of the joint, code first the underlying disease. Now, why is it important to put it in sequence? Well, certainly on the hospital side, it's hugely important because it has a huge impact on the DRG. On the outpatient side, it's important because a lot of rules and edits and other sorts of things expect things in that first position, and sometimes that's all they use. So, and it's important if it impacts payment or does other things, it's got to follow the guidelines or it could fail an audit. So sequencing is important, really important in the hospital, not quite as important. The rules for sequencing are relatively straightforward. It's the exceptions that get you, right? But the general rule is, if at the conclusion of treatment, that was the primary reason the patient was treated, then that's coded primary. Now, some folks say, well, the patient came in to see me because they had pain in the hip, right? But during the visit, I got an x-ray that shows that they have advanced osteoarthritis primary to that right hip. Well, I would not code for the presenting symptom. I would code for the diagnosis that I could make at the conclusion of that encounter based on the information I have. Right? That makes sense? Some people just think the presenting problem is what you code first. No, it's at the conclusion of your evaluation what you think the primary problem was that the patient was treated for. And that rule holds 98% of the time. There are a few exceptions. Most of them are related to OB and neoplasm. There's some strange rules there, but for ortho, that pretty much holds. Code also, pretty straightforward. Patient has enteropathic arthropathy. I would not code psoriatic arthropathy with it. It just doesn't belong there. Now, I don't know why. It seemed to me that was obvious. I wouldn't code those two things together. Code also if the patient had Crohn's disease, etc. And then you'll see this use additional. Now, to me, it was very confusing, and maybe the coders can help me on this. The difference between excludes two, code also, use additional code, they're basically all saying the same thing. Right? Any big differences? Any coders that can tell me what that difference is? Because I don't know. So I just kind of merge them all together. Just use another code if it's relevant. Right? It's really all the same. All right. And then occasionally we'll see these other informational notes. This is a big one. It says, use an external cause code following code for musculoskeletal condition if applicable to identify the cause of the musculoskeletal condition. Now this gets back to the whole issue of third-party liabilities, industrial insurance, and other types of things. There is a huge shift in focus on external cause codes. Now, up until, and depending on where you are, there's always been a big focus on the E code, so to speak. I know in this state, E codes haven't been a big thing, or from a payer standpoint, Regents never used them. I know that state Medicaid didn't use them, at least not consistently in their rules. But in a lot of other states are required. I was just working in Wyoming. They're requiring these codes be used. CDC has just put out a big article talking about the importance from a national perspective in collecting external cause codes to understand population health, population safety, a variety of different. GAO came out and had a scathing report about Medicare because they're leaving millions of dollars on the table because they're not collecting these codes. AHRQ has come out strongly in favor, so we're seeing this big push to move to the external cause codes. So we're going to talk about them a little bit because if you haven't been capturing these external cause codes, they're very different and they're related to every injury. Right? So they have a huge impact on musculoskeletal care. We'll talk about those a little bit more in a second. Seventh character, that's what we just talked about. There's certain types of conditions, mainly all the fractures, almost all the fractures that have a seventh character that applies to everything in that category. It says if you have one of the codes in this category, it must always have a seventh character. Now, we talked before a little bit about some of the quirks in the coding. Tendon and ligament injuries. Traumatic ruptures of ligaments appear to be confined to the hand and upper extremity, mainly the hand, right? You see in the hand there's a lot of codes for traumatic rupture. You won't find codes for traumatic rupture of ligaments in the lower extremities. What you will find is for spontaneous rupture, right? Now, that's a quirk in the system, but if you see someone with an acute anterior cruciate ligament rupture, you have to code it to spontaneous rupture. Now, hopefully that's one of those things that will get addressed in the next versions of IC10, but it's a challenge today. Because people were not at the table. We know, right? I can tell you that, well, part of this group, WEDI, the Work Group for Electronic Data Interchange, one of the roles of WEDI is to advise CMS about this. We've sent it to them, right? But they haven't heard it from the Orthopaedic Academy. So they're not sure that what we're saying is got the backing. I talked to the folks that I knew at the Academy. Well, you know, I'm hopefully get to some other folks to say, hey, this is a big issue. They said, no, that can't be true. And that's as far as I got. Anyway, that's just a whole different thing, but getting the Academy involved in addressing some of these things is really important, but it's very tough to get them involved in doing that. So. But anyway, it's just an issue. We're continuing to push on that and hopefully get it in some errata. Right now the codes are frozen, so we will not see a change in this for the next 2 years minimum. And then we use different words. Sometimes it's called rupture, sometimes it's called disruption, so you always, again, have to be careful about the terms you use. Tendinitis is virtual. All tendinitis in the upper extremity are classified as calcific tendinitis. So whether they're calcific or not, you're going to probably have to use a calcific tendinitis code because that's all you got. Tendinitis in the lower extremity includes both calcific and non-calcific for most, but for some reason in the upper extremity that didn't happen. Also in fracture classification, the concept of open fracture is used throughout almost all the codes, but is missing for certain types. For example, there are no codes for open pathologic fractures. Now, you're not going to see them very common. What it means is you have to code it as a pathologic fracture and you have to also code an open fracture of where that is. In most cases, we're going to see Gustio-type classification, but not always. There's a lot of open fractures that don't have that. There's some that always have that, so you always have to use it. Fracture of the femur, fracture of the tibia, fracture of the forearm. If you say open fracture, there is no open, you have to pick something relative to that. Most fractures are classified as displaced or not displaced, but not always. The general rule is if it's not listed as, excuse me, if it's not listed as displaced by default, as non-displaced, by default it's considered displaced. If you don't have clear documentation that it is non-displaced, you're assuming that it's displaced. That's what the guidelines are. All right. Touched on this one before. The whole issue of aftercare things has changed. We used to have 20 codes for aftercare, upper arm, lower arm, etc. Now we have 11,000 codes related to some form of aftercare. A lot more codes. Here's what those 7th character patterns are. Now the 7th character, generally if it's an A, will mean this and this. This is true for fractures. Other conditions, they may use A and it may mean something else for the 7th character. But for fractures, any fracture, these are pretty consistent. You won't see. Now sometimes they don't use the whole list depending on the fracture, but A always means that for fractures. B always means that for fractures. So that piece is consistent. And then there's the X placeholder, and I don't really want to get, this really should not impact you because the codes already have the placeholder in them in general. So you generally don't have to worry about that. All right, let's talk a little bit about external cause codes because this is a big area. And how much it will impact you, I'm not sure. In the state, I know that in a number of areas it's impacting a lot, and I think there's a lot of pressure to get these external cause codes. And for the purposes of third-party liability and claims management and coordination of benefits, these codes really are very important in terms of getting those claims handled appropriately. We used to have in IC89 the E codes, well, we still have them, and the E codes, and they were all start with an E, right? Well, we don't have that anymore. There's no E codes, and actually the external cause codes are actually spread over different areas. The reporting external cause codes includes, so if I see a patient come in with an injury, the guidelines state I should state the cause. We'll show some examples of that. I should state the external cause status. I'll show you what that means in a second. Right. The place of occurrence and the activity, where appropriate, because sometimes that doesn't apply. But the anticipation is that when you first see a patient with an injury, there should be at least 3 external cause codes. And I know one of the payers I'm working with now, that's going to be an edit. Right? If the injury comes in and it doesn't have those 3 external cause codes on the initial injury, then it's going to be sent back to get those codes. Now, that's just one payer that I know about. So, and everyone is very different around this. The rule is also that you're to use as many external cause codes as necessary to fully define the external cause. These codes should never be the first code. You would never use one of these codes as the initial code. There's always some condition, and then there's the external cause codes. There are some codes in the T series that are around toxic effects and other things. Those do not have to have an external cause because that's built into the code. External cause codes, the actual cause is to be used for the duration of treatment, but the external cause status and the place of occurrence and activity are only used for the first encounter. There's too many rules here. But anyway, I didn't make them up, so I'm sharing them with you. Place of occurrence, activity, and status codes are only used for the first episode. If the intent of the external cause code is unknown, you put accidental. All right. Here's how those former E codes map out. If we took all of the E codes and we looked at it, we ran it through the GEMS tool, you're going to see this is how they spread out. A bunch of them over here in Y, X, a lot of them in V, there's a bunch in T, and a few over here. So they're not all in one place. They don't all start with E anymore, right? They're just kind of spread out. And the guidelines tell you which group of codes is in which area. There is also an external cause table that is like the alphabetical index, but it's a separate table. So if you just want to look up Carl's, I've used this table before. I find it rather unhelpful. This is an area that I'm currently working on a tool to try and get to handle all these because I haven't seen any real good tools to be able to find these things. So here is the external cause codes. And these include all those codes like skateboarder colliding with a stationary object, passenger pickup, falling from a moving wheelchair. There are lots and lots of these codes, and if you ever want to get entertained, this is where those fun codes are. Right? These are the codes that people point to and go, see, ICD-10 is ridiculous because it's got all these dumb codes, like hit by a spacecraft, like suicide by paintball gun. How you do that, I have no idea. I mean, I'm sure you could think of a more creative and less messy way to do that. Yeah, but those are ICD-9 codes, right? This is nothing new. We've always had a code in ICD-9 for hit by a spacecraft. As a matter of fact, those codes have been dramatically increased in ICD-10. You want to know why? Because of NASA. NASA came and said, we need to track the injuries that are occurring with our spaceships, and we need better codes to be able to track it, so we need them. If you don't work at NASA, don't worry about those codes, right? It's not meant that you're hit by an alien or anything like that, you know. So you'll see a lot. Now, you know, and so we have more codes, and they've expanded in this area, and a lot of them seem kind of silly. Matter of fact, I think a lot of them are pretty silly when you look at them and go, oh, what does that mean? I'll show you a couple of those. But for example, we've always had a code for fell off a toilet. We know that happens. Why would I want that code? Well, maybe We're looking at a whole bunch of patients in nursing homes who are falling off toilets, and we're seeing hip fractures related to that, and we want to do some policy to intervene on that, or it's all coming from one nursing home, or that's what people want to know. We've always had that code. However, we now have 3 codes for falling off a toilet. You fell off the toilet and you hit your head. You fell off the toilet and you didn't hit your head. And you fell off the toilet and have no idea if you hit your head. Right? Now, those codes generally apply to fraternities, and other types of things where there's alcohol problems. But we have more robust codes. The thing is, you only use the ones that make sense. The challenge is finding these codes. Not necessarily so easy to find these codes because they don't fit nice little buckets anymore. But nonetheless, this is what they are. And then we have some combination codes. And these are codes that says, hey, look, we've got a code for this condition, but we've already included the cause, right? So you don't need an external cause for this. Some of my favorite codes, I think I've had a couple of these. Poisoning by caffeine accidental. Hopefully you're not trying to commit suicide with caffeine. That's a terrible way to go. It's not a calm way to leave this world, right? Caffeine assault. That's going to be a little perverted, right? But, I suppose, or you could have contact with a venomous frog, intentional self-harm, or assault, throw a toad at somebody, or so if you want a little entertainment value, you can see that because they do this sort of blunt thing, right? They have this thing and they apply all the things that could happen, and some of them sound kind of silly when they all come out, so we end up with a lot of stuff. But you'll see some of these things out there. Now, the external cause status codes. This one here is not a code, really. I put it in the list as a trick question. This is Y99, but because it has children, so this is not really a valid code, so that needs to go. This one here, and this is just redundant, this one here says Y999. They have a code in there, but the guidelines say don't use it. Doesn't that seem silly? Why put a code in there and tell you not to use it? But anyway, so you don't use that one. So what happens is, and you should not use unspecified, so there are really 4 codes that you would use. But these are very important because these are really key roles for TPL, third-party liability, civilian activity done for income and pay, military activity, volunteer, or other. Right? Those are the 4 codes. Now, so if it's military, you know which code. If it's work-related, you know which code. If it's volunteer activity, you know which code. And if it's something else, you know which code. So there's 1 of 4 codes that you use. So that one's pretty easy. And then there's a whole list of place of occurrence codes. Where did this happen at? Was it a public building? Was it a parking lot? Did it happen on a beach? Right. Yeah. Slaughterhouse. For those of you who frequent slaughterhouses, could happen. There's a list for most things. Now, what do they do with these codes? They track them to see where are injuries occurring, what types of causes are occurring, what was the location, are they work-related, is it other sorts of things? These are used for those purposes. Right? Or activity, right? Now, this doesn't apply to everything, but if you're doing very strenuous yoga and you injure yourself, here's a description for that. Ice hockey. If you're very vigorous with your drum, you could hit yourself in the head, I guess. Milking an animal, we all do a lot of that, right? Well, you could get kicked. Right? So there's codes for just about everything. You'll only use a few of them, but again, the challenge will be is that the guidelines state you should say, what was the status, one of those 4 things, what was the cause, what was the place of occurrence, and if relevant, and a lot of codes, this isn't relevant because there really is an activity form. Which activity was done, right? So potential of 4. Okay, so the question was, which ones will we use on the initial counter? Only the external cause codes. And if you go to the guidelines, the ICD-10 guidelines, and look under those external cause chapter, what you'll see is a range of codes that says these are external cause codes. The place of occurrence, the external cause status, and the activity are all on the first encounter, but only the external cause is reported on all subsequent encounters. And the reason it's reported is so that it can line up, so when they're trying to determine is this claim related to a previous third-party liability thing, it lines up at that level. But you only have to put external cause on all of them. The other codes is only on the initial encounter. Clear as mud? Yeah, go to the guidelines. It'll clear it up. You'll wish you had, no, go to the guidelines. Yes?
Heard in a discussion that now that we're going to put these external costs built in, does that mean insurance companies won't delay or deny our payment because they're waiting for the patient to draw the medicine?
Yeah. So the question is have I heard that payers are going to use these codes and may deny or pin claims if they're...
Because right now they deny or pin claims and they say we got to wait for the patient to show up. So we have our patients' levels report come in, so we don't have to sit there and wait for it. But instead of having that extra paperwork, will the payers now use this and not require the instant report?
Good question, and that gets back to the old thing that I said before. I will not guarantee that payers will do anything logically or rationally. Right. However, there is an opportunity to work with these external cause codes to eliminate a lot of those codes that would not possibly be third-party liability that are now falling into that bucket. So currently I'm working with a state Medicaid right now, and we've set up a program for what those edits would be. And the way that is set up is that there may be certain condition that triggers the rule, right? Fracture femur. Now look at external cause. If the external cause is not military or work related, let it go through. If it occurs in one of those external causes that's highly unlikely to be a third-party liability, let it go through. Because what's happened, and in this particular state they were very worried, traditionally Medicare has had a very blunt axe to third-party liability. It says everything that's in the 800, 900 range. Well, in that range of codes are a whole bunch of things that are totally ridiculous. They make no sense from a third-party liability standpoint, but all of those claims were dropping for third-party intervention, right, which caused a big delay in claims. Now we have 39,000 claims that would fall into that bucket of potential injuries, right? And I just walked through the mapping of this with this state. We looked at all those and they go, oh my God, we're going to be dropping all of our claims. And we just had a big discussion with CMS 2 weeks ago, and CMS says, you know, that 809 thing doesn't really work. And by the way, CMS is not going to come out with a new set of guidance for those codes. So you guys figure out which codes are likely to be third-party liability, and those are the ones you're required to do, because CMS requires the states to do third-party liability assessment. So what we're looking at is how do we get that list of codes down so that when they see the claim, if it's highly unlikely to be a third-party liability, it doesn't get held up. And if it does have third-party liability likelihood, then it would. So to try and make that a better sieve. If they do that correctly, it'll work much, much better. However, I can't guarantee they'll do that correctly. Right? And I've worked with, I think, 4 different payers on this, and some of them do it pretty good, and others say, nah, we're just going to drop everything. Right? So it all depends. Now, hopefully, they're going to use those for a better purpose. But right now, I don't even know how they're going to use those in this state. Yes?
We discussed earlier about the above and below diagnosis codes here in the state of Oregon, and the line seems to be dropping, the benefit line.
Yeah.
And so if we're looking at one time trigger finger was below the line, how are these codes going to affect versus fractures above the line.
Right.
But what am I looking at, because we work so much with Oregon Health Plan?
Yeah. Well, that's a very, very loaded question, obviously. So the question really is, how does this impact the above the line, below the line thing here, right? Because you guys do stuff very differently when it comes to that above the line, below. I don't know any other state that does that, right? And I've been to Oregon Medicaid 3 different times. We've looked at their policies and rules, we looked at their mapping, we gave them some guidance on how to do things, but we had the discussion about the above the line and the below the line thing. Medicaid has absolutely no control over that. That's passed down. And we actually had someone come to one of our meetings talking about that, and they were talking about, oh, we're just going to crosswalk that stuff. Well, they don't get it, right? Because it's not going to work if you crosswalk that stuff. So my big concern is the whole above the line, below the line thing is a big unknown right now. I don't know what that means. Now, that being said, in terms of the external cause codes, as far as I'm aware, they're not using any external cause codes in the above the line, below the line. Okay. That doesn't mean that we don't have challenges, right? But these won't apply unless they've changed that recently. I mean, I can't say 100%, but I don't think that they're using those for these. They might, but I don't think so. Yeah, that whole above the line, below the line thing, that is really worrisome. Move to Washington. All right. Now, basic anatomy. You know this stuff, right? Hopefully all of us orthopedic surgeons know this inside and out and can give this. But I just wanted to use this as an example to look at how we're using anatomy in the codes and why it's important. Okay, so we have a femur, and you know all the moving parts of the femur, and we have a subcapital fracture, an intertrochanteric fracture, or a subtrochanteric fracture, right? And you go, well, yeah, that only an orthopedist could love that stuff. What do we care about that stuff? Why is it important? Well, if I look at those 3 fractures, what we'll find is that if we look at the risk of mortality and morbidity from those 3 fractures, they're substantially different. Right? Because we know one of the key factors in terms of mortality from these hip fractures, the one that my professor drove into my head, he made us put a stopwatch on every hip fracture we treated, and we were judged on how quickly we did the procedure. Because he said, you know, it's how fast you do this operation to whether they live or die. Now, that's a little over-exaggeration, but clearly the length of time under anesthesia for a patient with these hip fractures is a huge factor in terms of mortality. Right? In terms of morbidity, one of the key factors is how soon I get that patient up walking. The likelihood of them having an atelectasis or some postoperative respiratory problem is greatly increased if I don't get them walking right away. Right? Key factor. And let's just say your grandmother comes in. And your grandmother comes into the emergency room, you get a call, and you say, let me talk to the orthopedist on call. You talk to the orthopedist, and you say, is it a subcapital fracture, an intertrochanteric fracture, or a subtrochanteric fracture? Right? Because you know this stuff. And the orthopedist, who is obviously amazed by your knowledge, says it's a subcapital fracture. And you go, oh, thank goodness. Right? Because I feel pretty sure you can put a prosthesis in that 20 minutes skin to skin, if you did. Right? And you can get grandma up walking on it, full weight bearing tomorrow. The risk of morbidity, mortality, probably less. If it's intertrochanteric, I'm going to have to put a plate and screw on it. Could take a bit longer to do it. If it's a subtrochanteric, I now have an intrinsically unstable fracture that I'm going to need a big plate and screw or a Zickel thing. I don't even know whether they're using Zickel things anymore, but used to use this old Zickel. You know, a lot bigger procedure. Right? The risk of morbidity and mortality from those 3 fractures is different, and they're only 3 inches from each other. small differences in anatomy make a big difference. If I have a patient coming in with a fracture through the shaft, mid-shaft of the femur, if it's a oblique, spiral, or segmental fracture, I'm going to be really worried about it. If it's a young kid who comes in with a transverse fracture, I know I can put a nail down that and pretty much get them up the next day full weight bearing. Right? Pretty stable, big differences. If it's lower down, it makes a big difference. If it's a supracondylar fracture, it's totally different treatment. And if it's intra-articular, totally different. Right? So small differences in that anatomy. If I just say fracture femur, I'm really not capturing some of those differences. If we look at some examples of those fracture codes, age-related osteoporosis with current pathologic fracture, left femur, initial encounter. Stress fracture, displaced mid-cervical fracture, open, type 2. Unspecified fracture, which of course we hope we wouldn't use, but sometimes actually unspecified is the only fracture you can use because it says it's not a stress fracture, it's not a torus fracture, and they don't really have one for, you won't find anything that says traumatic fracture. So seeing unspecified fracture, don't worry about it. That's not really an issue. It doesn't mean it's really unspecified. It means that, you know, it's not one of the others. Intertrochanteric fracture, transverse fracture, non-displaced, lateral. Now, the one thing I did want to say about unspecified, sometimes you get the option of using unspecified or other. Right? Looking at the code, it means the same thing. I don't know what it was. But if it's not on the list, it's another. If you didn't look at the list, it's an unspecified. The way that most payers are going to look at it, they're going to look unkindly at unspecified, but other is okay. Now that doesn't mean, and unfortunately people use other and unspecified interchangeably, right? But in theory that means that, you know, if you use other, you're less likely to have that code justified or looked at as a unspecified code. So it's better to use other, but you have to be able to actually support that you actually looked at those other categories and it wasn't one of those. All right, so let's talk a little bit about what do we do to strategize to try and reduce that burden of data capture. Right? We can't, it's not a good idea to have the orthopedist sitting there and capturing all these data points that don't need to be captured by the orthopedist, right, the physician. If we can capture them, in my office I actually trained an interviewer, right, and every patient that came in with a knee or a back problem or some other, I actually had some condition-specific interview forms, and she would actually capture all of this stuff. And I would look and say, oh, I see all these things are true here, and I might add some additional questions. But I tried to move as much as that as I could in front of that patient-physician encounter so that I had the data, I confirmed it, I reviewed it, but I didn't necessarily capture it. Now, as I mentioned before, a lot of organizations are using scribes. And I actually had to go see my physician last month sometime, and there was the scribe doing all this. It was actually a pleasant experience. I actually talked to the guy, right? The scribe was, and the scribe every once in a while thought, oh, did you ask him about this? Actually prompted him about some of these things, but captured that information. And the intake sheet that I had captured a lot of data right from there. Now, sometimes you see those intake sheets and you wonder, what were we thinking about them? Because they're redundant, and you know, you ask the same question 25 times over, which really irritates the patient. You know, didn't I just put that on the form? You know, drives them crazy. So streamlining that intake process that's data focused, it captures the key data that's necessary for good patient care and addresses the issue you need for coding, is something that you have to plan for and build for. I was working with a hospital in Southern California, and they are building templates, and so they're going through these templates, and that's one of the things we're looking at. All right, you come in with asthma, what's the template I need? Diabetes, what's the template I need? So, and I'll show you a little bit about what that looks like. But there are a limited number of concepts. There are 1,700 codes for fracture of the radius, but there's only 50 concepts, right, in that 1,700 codes. Physician doesn't need to capture everything. Use other resources. Have the patient capture as much as they possibly can. They're a free resource. You need to prompt for the right stuff. If someone has an open fracture, what Gustio class is it? If they have a physeal fracture, which Salter-Harris class is it? If they have a subsequent encounter, normal healing, delayed healing, non-union malleus, right? Identify those things. And you have to be very careful about copy and paste. Now, since we never see the same two things twice, we don't have quite the same issue, but I can tell you at CMS and Health and Human Services, they've raised this gigantic issue about copy and paste. Because what they're seeing is, and particularly on internal medicine family practice, they're copying, pasting a whole bunch of stuff over that they never asked the question, and it's not correct, and it's not good care. Right? So there's a great deal of concern about that. So anything that you copy and paste that has not been verified and relevant to that, you've got to be really careful of that. Because that's not only bad for documentation, it's also bad for patient care, but suddenly we're assuming stuff that may not be true. All right. So what do we need to do to prepare? And I don't want to imply that this is a disaster. I actually think it's going to go smoother than we think, right? But it's a huge unknown. And so whenever there's a huge unknown, you want to run some scenarios to check it out. If you want to make sure that you could survive a fire, you run some scenarios. You do a fire drill. Right? Do we know the exits? Do we know the extinguisher is? We know all those things. How do we do that? We pretend there's a fire, and then we do the drill, right? Because it's much better to find out you don't know where the fire extinguisher is during a fire drill than when you're on fire, right? So the whole idea is to try and create risk situations, analyze that risk, and then look what you need to do to mitigate it, because you may think things are just fine until you actually run those things that you see all the time. The OB guys that I was talking about, they thought everything was just fine until they ran it and go, oh, wait a minute, oh, zero. Right. Big deal. You discover those things during a drill, which is really what scenario-based testing is all about. So, what is this scenario? The identification of some event or condition that we are familiar with today, recreating that event virtually through some virtual or data representation. If you really want to be creative, dress someone up, put blood on them, that sort of stuff. Walk them through your office. Right? At some level, you want to try and recreate that. Define a variety of assumptions and of variables around this virtual representation. Here's a patient came in, they had a hip fracture. Well, what if it was open? What if it was closed? Those different types of things. And you apply these scenarios to a reference implementation model. We call them in the technical business RIMS, reference implementation models. And basically what this means is we're going to take that scenario and we're going to simulate it in a virtual environment to try and see if we can break it. And the whole goal of this type of testing is to try and do something where you can break it, right? You don't want to prove that you're good, you want to prove where the problems are. So the goal of scenario-based testing is to model today's experience to minimize risk and leverage the opportunities for future change. Right now, you're just trying to minimize risk at this point. But identify points of risk, identify requirements that you may not have, virtually apply alternative assumptions and variables, virtual testing of the options that you do to fix it, and you need to have some sort of plan for how you're going to do all this. Now, you don't have to have this extensive, comprehensive test plan and test models, but what you do need to do is just kind of think that through and have some type of plan out there for how you're going to do it. The general rule is the level of risk that you're willing to deal with is directly related to the level of testing you're willing to do. Right? If you don't test anything, Risk is like that. If you test a few things, risk has gone down some. Right? The more you test, the less the risk. Now, and you have to draw that line to whatever is comfortable for you. So it's impossible to identify every process potential area of risk, but you can minimize that risk by focusing on those things that represent high volume, high cost or revenue, high complexity or likely areas of failure, or any place that you see where you think there might be some opportunity to improve. So if we take a scenario which presents some of that, then what are some of the areas it might be related to? Patient assessment, clinical documentation, the care process, coding, billing, policies, payment, all of those things. Generally, when I've done this with some organizations, we start right at the beginning, the first encounter of the patient with the physician or the symptom or the hospital, and we walk it all the way through triage, front desk data capture, physician for the same scenario, seeing what the documentation patterns are, creating a test claim, and actually testing it with the payer to see the result. Now, a lot of payers right now are looking for people to help test with them because their big concern is they don't know how you're going to code. Your big concern is you don't know how they're going to pay. So you have a reason to come together, and there's a whole lot of payers, and I've never seen this in things like this before, where the payers are actually reaching out in many different areas to bring providers in to test some of these things end to end. You send me the claim, I'll tell you whether we're going to accept it, and I'll also, and some of them are actually running it all the way through to an 835 payment transaction. Right? Good thing to test early on. All right. So let's look at one of these scenarios and see how some of these things apply. So here we have a 30-year-old male patient who was working on the weekend for the National Guard. The car he was driving collided with a military vehicle on the military training ground. He was seen for the first time in the emergency room with an open, and this is seen first time, the orthopedist seen him, in the emergency room with open display supracondylar fracture of the right distal femur with intra-articular extension. Opening is greater than 10 centimeters with significant contamination and tissue damage. So that's the medical concepts that I have, right? Now there's none of those concepts you can say, well, we could do without that one, right? I can't treat the patient if I don't know some of those concepts. Now you could say, well, we don't need to know all that stuff. Well, you really do. Right? To be able to handle this claim properly, to make sure that we understand this, we need to have those things. And from a coding requirements basically I need to capture those. So how might I capture that? Well, one thing I would do is build into my process a way that I just routinely capture for every injury. What was the date? Was this the initial encounter, subsequent encounter, or was it for a sequela? What was the work status, right? Were they on the job? Was this military related? Was it volunteer? Because we know those all go to a specific code. What was the place of occurrence? And again, describe the place specifically, but was it commercial, public, etc.? What was the cause? This was a collision for this particular example. It was vehicle related. Patient was the driver. It was a car. It collided with another vehicle that happened to be a military transport vehicle. It was related to military activity and it was accidental. And then what was the injury type? It's a fracture, and we'll go to see that fracture template. But what was the type of injury? And then based off of the information I capture, including that clinical documentation I had there, I come up with this code: display supracondylar fracture with intra-articular extension, lower end of the right femur, initial encounter for open fracture type 3A, B, or C. Here's my code. Secondary diagnoses, external claim status, military activity, cause, car occupant injured in transport with military vehicle, place of occurrence, military training ground. Well, yeah, but I'm not selling that here, so. No, we'll talk about how you get that, but it's doable. Right? It is doable. I've been working on a prototype. You can get those codes fairly rapidly. I've been running these scenarios, and I can get to these codes in under a minute. Right? But it all depends on which coding models you're using. That's why you really have to create these scenarios and then run them through and see to what degree you're able to get to the correct codes given the tool that you have. That's part of the assessment. All right. I want to do a quick shift here because I want to show you what a fracture template might look like, for example. Oops, I think I need to go back. Missed it. So, for example, and this is a Word document, so I need to scroll down through this. This might be some of the concept. Now, this is not all the things that you might consider, but and if I had an EHR, I would make these much more conditional. There's ways to set up the template, but things you might want to capture for. I've got that patient coming in, I've captured those different things. Now I said, oh, they're a fracture. What else do I need to capture about fractures? Well, if it's a subsequent encounter, whether it's normal, delayed healing, non-union, or malunion, what fracture type, open or closed? You know that impacts a lot of codes. Was it a traumatic, an avulsion fracture, pathologic fracture, etc.? If it's a physeal fracture, which Salter-Harris class? Which bone is involved? Which part of the bone? And it's going to vary depending on the bone. Some have head and neck and some don't. Whether it's a condyle, and if so, is it bicondylar, etc. If it's a malleolus, medial malleolus, lateral malleolus, bimalleolar, trimalleolar. If it's a named fracture such as Collie-Smith, Galeazzi's, etc. These are some of, or most, whether it's which laterality, other things like it's proximal, distal, etc. So there is a finite set of concepts that can be built, if they're built properly, into a template that will help you capture those things that you're going to need on a regular and consistent basis. You need to go out and look at those codes to figure out what those are. Now, the other thing is, I just put these templates together for educational purposes, but I will send copies of these to Jessica also to look at just to get some ideas. Now, don't go out and say this is everything you need to capture, right, or how you need to capture it. But if it gives you some ideas about some of the things you need to capture, I went out and I researched what are those, some of those common concepts, and they're in here. And if you send a note to, you may get some emails. You're okay with that, aren't you? So the slide presentation's here today, and we'll put in those models that I'm showing here, and you feel free to take a look at those. The other thing is I do have a bunch of white papers on my website, so feel free to download any of those you want. And then we're going to take a quick look at this gem mapping tool. I want to just show you how it works too at the end. So. All right. Are we still awake? Okay. Are we still having fun? Oh, maybe. All right, let's pick another scenario. Here we have a 9-year-old male who was playing on the swing on the weekend at elementary school, fell from the swing. He presented to the emergency room where x-rays revealed a closed Salter-Harris physeal fracture of the left proximal tibia. Okay. Not a ton of documentation, but a lot of stuff in there, right? A lot of concepts, and those concepts that drive those things in red, those concepts is what I'm going to pull out and put in my code. Sorry, that closed should have been red. So based off of that, here's my primary diagnosis, Salter-Harris, type 4, physeal fracture, upper end, left tibia, initial encounter for closed fracture. Now you notice that I said proximal. Now upper end is the same thing as proximal. But if you look for proximal, the word, you're not going to find it. depending on the tool. You should say, oh, you mean upper end, but most of them don't do that. Secondary diagnosis, other external cause status, right? This was not military, it was not volunteer, it was not work-related. Fall from the playground is the cause, from the playground swing is the cause, and this was the initial encounter, because some of these causes have initial subsequent sequelae also, and place of occurrence, elementary school as the place of occurrence. Any questions during this? Again, feel free to interrupt at any time. All right, let's try another one. And when you get these, try them yourself. Right? Walk through and try and find the codes. It's a good exercise to see how tough or easy it's going to be, depending on the tool you have. Good. So here we have a 49-year-old male with a history of chronic drug-induced gout. He has tophaceous deposit seen for the first time, presents with localized swelling in the left foot, right? So we know that this is gout. It's in the foot. It's on the left side. It's tophaceous deposit. This is the first time they see. And we know that sex and age aren't going to factor because they're not included in the codes, but still, it's an important concept. Here's my code. Now, this is not an injury, so I don't have any external code. Hallelujah, right? We don't have to do that. Drug-induced chronic gout, left ankle and foot with tophus. If this patient had lead-induced gout, we have a code for that. If it was idiopathic gout, we would have a code for that. All right. Now here's a challenging one. And it's got some tricky stuff in it, but it says we have a 62-year-old male seen in follow-up for pain and stiffness of the left knee. His range of motion is 20 to 90. He's using a cane, can only walk approximately 2 blocks. Because of his primary osteoarthritis, which has been defined previously, limited to his left knee, he has a chronic effusion. He also has type 2 diabetes with peripheral polyneuropathy involving both lower extremities, as well as intermittent claudication, both legs because of peripheral atherosclerosis. He also has migraine headaches. Right? Not terribly unusual to see something like that. The question is, what do we code? Now, when we look at this, we say, well, look at all these things I could code, but the rule is if the symptom is associated with the disease, you wouldn't code it. So, would I code pain, stiffness, left knee? No. Would I code anything about his gait limitation? No, right? That's not unusual to see with primary osteoarthritis. Would I code effusion? No. Right? Not unusual to see effusion associated with these things. So I don't have to code any of those things. But I do need to code his primary reason for being seen, which is primary osteoarthritis, limited to his left knee. That's the primary reason he's being seen, so that would be number 1. Now, he also has diabetes with peripheral neuropathy, and he has claudication from atherosclerosis, and the claudication in both legs that obviously could also limit gait. Diabetes, atherosclerosis can not only impact the results, but they could also cause increases in the levels of complications associated with this, right? So to recognize that, we want to make sure that since those are relevant to the patient's primary diagnosis for being seen, that those are coded also. Would I code migraines? No. Sure, he's got them, but what does that have to do with anything, right? Does that increase his risk or severity have anything to do with it? No. He may have other problems there. If they don't really have anything substantial to do with that, then you don't code it. If the physician says, you know, that type 2 diabetic polyneuropathy has no impact on what we're doing here, don't code it. Personally, I would code it because I think it does have an impact, but it's a judgment, right? So here's our codes. Unilateral primary osteoarthritis of the left knee. Seems like that would be a bit redundant, doesn't it? How could you have bilateral of the left knee? I don't know. But anyway, that's the code. And a secondary diagnosis, type 2 diabetes mellitus with diabetic polyneuropathy. We used to use 2 codes for that. Now we have 1. And atherosclerosis, native arteries of the extremities with intermittent claudication, bilateral legs. Right? Those are the codes that we capture. Questions?
Say you have a patient come in with the diagnoses you say doesn't have the GP, and you decide, I think you need to see a new family doctor, get a family doctor to treat your migraine. So wouldn't you go to the migraine?
No. I would document the migraine, and I would document that I referred them, but the primary reason the patient is being seen, the migraine has nothing to do with it, so I wouldn't document. Only if it had an impact on the primary reason the patient is being seen. Because otherwise you could document just about everything. You know, you got to really draw the line on that, as we mentioned before. So the general rule is, if it's something that would have an impact on the risk, severity, or complexity, or make a difference in how we would treat the primary reason that the patient was being seen, then we don't document it unless it does those things. We would also not document signs and symptoms that are normally associated with the condition that's the primary reason the patient's being seen.
Okay, so I would document the migraine. What if I take the blood pressure for the first time and it's 200 over 100, and I think, you know, you really need to see your GP, even though I'm seeing you for your knee, I've documented hypertension too, and I diagnosed it.
I would document it, but unless I was treating the patient for the hypertension, I wouldn't code it as an orthopedist. I would document it, but unless I said, oh, you know what, I'm pretty good at treating hypertension, I'm going to put you on some low pressure, we'll see you next week. No, yeah, then. Yeah, but that's a little bit different. Yeah, no, documentation should obviously document everything that could be relevant to that patient's treatment or referral or anything else. Yes?
So this gentleman has osteoarthritis, and we're going to consider operating on his knee, and diabetes is a risk factor and a comorbidity. How accurate do I have to be with my ICD-10 code for the type 2 diabetes? I assume there's more than one.
There are, and you want to be as accurate as you can, right? Now, if you didn't go to diabetes school, right, and you don't know about the different types and what's secondary, I would just call diabetes unspecified or use something vaguer. But if I knew this stuff, I would document it as specific as I can.
Where does obesity fall in all this?
If obesity is a factor, this patient has a BMI of whatever, way down here on the list, right? I would sure document that. I would also document, because obesity needs to have 2 things to be documented. If I see a patient with severe obesity or morbid obesity, I would document code for the morbid obesity and the BMI. Right? There's 2 codes, and you want to document both. Because generally they say, how do you know it's morbid obesity? Did you have a BMI on them? And there's rules around it, so you should document both.
In what sequence?
What sequence? The sequence is always the primary reason the patient is being seen for. The sequence below that, it doesn't matter, right? There is no number 2, number 3. No, that would drive us really crazy. Yeah. No, secondary is just secondary, right? There's no rhyme or reason to sequences of secondary. Good question. Any other questions? Okay. All right, here's someone who fell from a toilet. And they struck something, so we know what it is. So here we have a 75-year-old male volunteer working in the nursing home, part-time as a volunteer, fell from the toilet in the nursing home, hits his head on the tub. He had a prior total hip replacement. He had loss of consciousness reported as less than 30 minutes. He was initially evaluated in the emergency room, and he was revealed to have a periprosthetic fracture of the left hip around the prosthesis. The patient also had a skull X-ray and MRI revealing a small subdural. You're the orthopedist seeing this patient in the emergency room. You note all of this stuff. You know that those things may or may not be important, but basically you're looking at this and say, what do I code? Well, number one, what's the reason the patient came to the emergency room? Well, it's because they fractured their hip around a prior prosthesis. There are special codes for periprosthetic fractures around internal prosthetic. You could use fracture of the hip. Which one is more severe? Periprosthetic fracture, right? It's going to make a big difference. So I'd clearly use that, not just use hip fracture. Secondary diagnosis, did have a fracture of the vault of the skull. He had a traumatic subdural hemorrhage, loss of consciousness of 30 minutes or less. He fell off the toilet with subsequent striking against the object. It was in the bathroom, in the nursing home, and it was voluntary activity. So I've characterized that. Now, you may, as the orthopedist, say, you know, that skull fracture and that subdural and the loss of consciousness, that has no impact on what I'm going to do. Don't code it. Somebody else would code that who's treating them. You wouldn't necessarily need to code that. You would know. So again, the rule is that if it's relevant to what you're seeing the patient for, if it would make a difference in the risk and severity and complexity, if you think that that's going to make a difference in the risk to the patient, I sure would code it. But that's the judgment call. So you don't have to code everything. You code those things that are relevant to the patient condition that make a difference in risk and severity or complexity or what you might do differently based off of that information. All right. And if you said fell off the toilet unspecified, well, you mean nobody knew whether they really hit their head or not, hopefully. But if you got a head injury and you say unspecified, go, wait a minute. How did they get that head injury, you know, if they didn't hit their head, you know. All right, meniscal tear. So we have a 27-year-old male dock worker who's seen in follow-up with complaints of pain, swelling, and catching in the right knee. He was at work, twisted his knee when he tripped on an object on the dock and nearly fell, but he caught himself, and a recent MRI shows that he has a bucket handle tear of the lateral meniscus. What's the primary diagnosis? Bucket handle tear, lateral meniscus, current injury, right knee, subsequent encounter. What's the secondary diagnosis? He slipped, tripped, or stumbled and fall due to stepping on an object, place of occurrence, dock or shipyard, and he was civilian activity done for income and pay. All right. Still having fun? Okay. Yeah, the fun part is actually doing these things. Right? Don't look at the results. Just take those scenarios and see how you do and see if you come up with similar results. Or maybe you're going to find out you coded it better than I did, so just look at that. It's a good. All right, so now we have an 18-year-old male. He attempted suicide with a knife wound to the right wrist. He was initially seen in the emergency room, was admitted for laceration of the radial artery and the flexor pollicis longus tendon. And being well vascular trained as you are as an orthopedist, you decide, I can take care of that radial artery tear. Who needs to call the vascular surgeon? Back in the old days, we don't do that anymore. But we're certainly going to be involved in treating that laceration of the flexor pollicis longus. So what would our primary diagnosis be? Well, since my primary reason for being there was laceration of the long flexor muscle, fascia, and tendon of the left thumb, at wrist, initial encounter. Now, laceration can include long flexors, it can include extensors, it can include specific defined tendons, but in this case, there is no one particular definition for flexor pollicis longus. It's simply a long flexor muscle, and it's at the wrist, not the forearm, not in the hand. Right? So those, you have those different levels. Involves the left thumb, and again, initial encounter. Now, secondary diagnoses. You might say, well, this laceration of the radial artery, that seems like it's a primary diagnosis. Well, only if you're the vascular surgeon treating it. Right? For you, it's the secondary diagnoses. So it's not which one is more important, it's which one is more the focus of what you're treating the patient for. Laceration of the radial artery in the wrist, unless I was treating that, then it would become primary for me, right? Because I think that's the more important of the things that I'm doing. But if the vascular surgeon is doing that, I would want to note that, because the fact that they had a flexor of the laceration of the flexor pollicis and the radial artery laceration may make a difference in risk and severity in what I do to treat it, how I handle that type of thing, what the potential complications could be. So I would want to record that. And I would also want to record that this was an intentional self-harm by a knife as a cause. All right, so where do you find information to start researching it? And hopefully any of you who started looking at ICD-10 has already been out to the CMS site, download all the tabular stuff, right? All free. It's queryable with a PDF. You can query through it and use it. I actually like it using better than the paper stuff because I can actually run a search through it. All of the tables that are out there that list all the codes, all of the indexes are out there. And this one is very important, the guidelines. Right? Now focus on the guidelines that describe generally about using the tabular document and chapter-specific stuff around musculoskeletal and injuries and external causes. Those are going to be the areas. You don't need to know the neoplasm. There's 150-some pages, but only the ones that focus on. But all of those will be out there. And they have a great deal of detail, and it's good to kind of start learning those things. Then it becomes second nature, just like a lot of the current guidelines we have around ICD-9 are probably second nature for a lot of coders today. CMS also has this provider resource page, and there's videos. I think you'll even see one of mine out there someplace. There's videos on clinical documentation. I did one of those. There's a number of documents in terms of introduction guides, transition, basic medical practice, some of this stuff. So there's some good stuff out there. There's even some test cases that you can do. So a lot of good information out there, and there's a place called Road to 10 that kind of gets you there. All right. So before, I did want to just show you real quickly, if I can pull it up, and this is just an experiment, we'll see, the use of the GEM tool, because that you may find that is helpful. Let me see if I can. All right, so I think this is working. We'll try it in a second. So on my website, you'll see this thing called resources, and there's a number of white papers that you can download. Again, all this stuff is free. Easy GEM-based mapping tool, and it takes you to this page here, and I would highly recommend you read all of this because this talks about the limitations of GEM mapping, general equivalency mapping, what it does, what it can't do, how to use this tool. And you do have to sign up so you can get a password. But again, it's all free, and I guarantee you no spam. So, but I've got to manage the logins to it. And I thought this would remember this, but apparently not. I hate doing this in front of people because then you show how badly you spell and how dyslexic you are. And how you can't get your password right sometimes. Ah, I got in. All right. All right. So, nope. I like nope. That seems so much more cordial than no. Nope. Nope. Google always has good things like that. All right, so super simple, right? Put this out there. There are a lot of people who are charging for these gem mapping tools. And I'm going, why? It's free and it's simple and just use it. Right? And you'll see some of these tools that, and I think AAPC has one where you put in a code and it maps to one code. That doesn't work. Right? You can't map to just one code. Sometimes that one code has thousands of codes associated with it. So to see all of the relevant codes, you actually have to look at all of them. But let's see. Of course, I don't remember. I never memorize codes. It's just a failing of mine. All right, so let's try and put in a code 81341. Now, some of you already have this thing memorized. 81341. So I could put a code in here and say, and it defaults it's an ICD-9 code. Kind of assumes that you're probably checking to see what the 10 codes are. So you put in a 9 code. You can either put in the decimal or not. The standard for submitting claims is no decimal, by the way. Even though you see them all the time, that's just like a comma in the thousand thing. It doesn't mean anything. So the standard is no decimal, but you can put it in the system, and last time I checked, at least it doesn't have any problem with that. And then I could say, oh, and mapping type. So mapping type says, do you want it looking at all the codes in both directions or in one direction? So in this particular case, let's just say that I want to look at how GEMS mapped it 9 to 10. And if I do that, there's my ICD-10 codes, right? So for that Colles fracture, there are the 2 codes that GEMS say that code would map to this. Right? Now, again, realize that one is that we never had Smith's fracture before, and so what used to be Colles is now mapping to either Colles or Smith's. Let's go back again. Generally, I tell folks, look at it bidirectionally because I want to see from a GEM perspective as many of those codes as I can. And we're going to look at it from the bidirectional. And bidirectionally, you see I get more codes. Right? To me, it's better to be able to pick. So this includes, now what you don't see in here, and this is a problem with GEM, with fractures, you don't see subsequent encounter. They didn't map to it. Right? So you just have to be aware of that. That's a problem, particularly with GEM mapping with fractures. But it just, again, gives you an idea. So what I might do is if I'm looking at codes that I see frequently, I might look and say, oh, I wonder what that would be in GEM. I would look at this and I'd go, oh, these all seem to be like S525. Let me go in the tabular index and see all the things that are in there, right? And then you're going to get much better. So it's better just to use this to give you an idea. Don't rely on this for coding. And I almost feel bad about even showing people this because you don't want to rely on this for coding. This is just to give you an idea of what space you're in ICD-10. Now, the other thing that you can do, let me see if I can make this happen. Let's say you have a list of codes here. So here, particularly, I have all of the, or not all of them, but I have a list of codes of fractures of the radius in ICD-9. I can do a copy of this, and then I can go, where is it? And paste all these codes here and say, all right, I want to find all of the 10 codes that relate to this list of codes that I just copied from my spreadsheet, and I want to look at it bidirectionally because that's the way you should probably look at it to find all the codes that I can, that GEM has. And again, this isn't all the codes, but it's all the codes that Jim could find. And here is the list of all those codes. Now, if you want to, you can also download those codes to an Excel spreadsheet. And there are all of the ICD-10 codes that Jim maps from that list of codes I put in. So again, this is free. Go out there if you want to play with it, use it, take some codes you know today, look out. Just be very mindful that GEM equivalency mappings are no substitute for coding. Right? It's only to help you do some research and background. All right, that's a lot of stuff to cover after lunch. Hopefully haven't gone too much into the detail or weeds, because you're going to have to get a lot more into the detail weeds, a bit later. So, but just wanted to introduce that. But let's start some questions. And Jessica.
So if I wanted to choose a mapping tool, and I just wanted to type in what the concepts were, can I get my code?
That's my other tool. Right. I'm prototyping a tool right now.
Because Codex, I don't believe, allows you to do that.
No. And actually, I was going to look at some of those things that we have in Codex, and I did. So, and this is where you need to apply those SARs. I took those, those examples I was given where you put in proximal femur fracture, try it in Codex, try hip fracture. You know what the answer should be, and see what you get. I can tell you Codex does the same thing. It brings a very limited set of hip fractures, and it includes chip fractures of the talus in that list, right?
Because it's searching on the word hip, and chip is hip.
Word searches, right? That's the big challenge here, is it's not taking the concepts. Now what I've done, and again, I don't have any product for this, I'm just prototyping this right now. I've mapped concepts like distal and intra-articular so that they're mapped to the code. So if, for example, a physician says intra-articular fracture distal radius, what will show up there is a Barton's fracture, but not a Colles fracture. Colles fracture is extra-articular, but the code doesn't know that. So you have to map the knowledge to it. You have to map the knowledge saying if it's subtrochanteric, intertrochanteric, et cetera, it is a fracture of the proximal femur because it doesn't say that. Right? So what I'm trying to do is take those concepts, and no matter how you say them, it will get you all of the things. And then what it does is it says, here's the list, and here are the other concepts that will narrow that list down. So once you get that list and you say, oh, right, displaced, et cetera, the list just goes like that. Well, I'll tell you, I've been working on this for 6 years. I've got 580 concepts mapped right now, and again, this is all research right now and prototyping. 580 concepts mapped right now. The number of maps of concept, or what we call meta tags, to the code is about 500,000. Right? But what happens is if you put in any of those things, it's almost bulletproof for orthopedics. I haven't gone to the other specialties yet, but for orthopedics, it's almost bulletproof. There are some places where you can trip it up, but the knowledge about what those things is built into the code, so it's not a matter of words, it's a matter of concepts.
Can we access that now?
No. However, if you're interested, I am looking for alpha partners to help me evaluate this, and so we can talk about that later. So I don't have a product at this point, but if you're interested in being an alpha partner, in other words, you can help me learn about this, I'd love to have you help me. And if you're an alpha partner, when we do make it a product, we're going to give you such a deal. So.
I assume that if there is an ICD-9 code that is useful, that when ICD-10 comes out and there's no useful code that you can find, like acute ACL traumatic rupture, there's no point in putting an ICD-9 code in there that has that in there to help you out, is there?
Yeah, here's the good news. We never had one. Believe it or not, and this is what drives me crazy, is that we've had ICD-9. There has never been a code in ICD-9 for acute traumatic rupture. I've looked. There's never been a code for it. Why didn't the Academy pick up on it? I don't know, right? No, you'll find all sorts of very interesting little quirks out there. Right? But the bottom line is if you have a code that you're using today and you want to know roughly what the equivalent codes are, that one thing, the gem mapper, anyone can use it. Feel free to use it. The other thing we're talking about is still very much in the investigational alpha stage, and I'm looking for people to help me make that better, but that's not going to be a product for, I don't know when. So it's going to be a while before that's a product. Yes? Yes, there are. There are. For the first time, these are for medications, right? So you got to be really careful. For medications, there are now codes for what they call underdosing, which is synonymous with or used also to mean noncompliance. So if you have a diabetic patient, there's a code for underdosing on insulin. No. Now, that's why I would like to see the Orthopaedic Academy get more involved in this, because if they go to the NCVHS table and they say these things are important for us to understand, we want new codes, there is a process for getting those codes inserted in there. NASA did it, right? They've now got 30 codes for hit by a spacecraft. Works for them. So, yeah, there is a process to get the code. It's through NCVHS, National Committee for Vital and Health Statistics, that runs this, submits these codes. Other questions?
Do you know if payers will require BSO-specific on finding, like, getting a surgery authorization? Because we don't know, need to know, like, how it happened, or just the diagnosis or like that?
Yeah, so the question is, what will payers need to have in terms of specificity? And all I can tell you is it's all over the map. I literally have been in, I think it's 46 state Medicaids, and we've done mapping for them, and not one of them does it the same. Right? They do it very differently. I can tell you that there is a big push towards external cause codes, and that some payers and some states are requiring them, and requiring them according to the guidelines. In this state, I don't know when that'll happen. I don't think it's going to happen right away. I think you've got a while for that. And in terms of using the specificity, I think that's going to take a while. I do know that a number of payers are already looking at and have already built edits for things like unspecified side, right versus left. Trimesters. In the one state I was working with, we actually put in the edits. If you say unspecified trimester, the claim gets sent back. If you say unspecified side, the claim gets back. And another payer, they're looking at a list of codes that in theory should relatively never be used, and if you send those codes, they're going to go, they need to go back. But that's highly variable. There is no generalization.
You were told in a meeting about a year or so ago that workers' comp and motor vehicle may not be ready to go ICD-10. It won't be required to, possibly this in this case, but do you know anything about that?
Yeah. So what she brings up is that technically under HIPAA there is a workers' compensation, casualty insurance is exempt, right? Now, that being said, CMS has reached out, and actually I saw a map that shows all the different states, reached out and said, look, this isn't going to work because we can't do Medicare crossover claims, we can't do anything. You can't be staying on ICD-9, it's just unacceptable. And almost every state that I know of has stated, you're right, we can't, right? We have to move to ICD-10. I know in Washington that was a decision that, yes, we have to go to ICD-10 because we can't function without that, and we can't require providers to send 9 and 10 codes in, right? Now, I don't know what's happening here in Oregon with that, so I can't answer that, but I would definitely look into that and see what they're doing, because it's insanity if they require you to use ICD-9 codes. I mean, that would be very messy. Yes, and most states are moving.
It oftentimes seems that insurance payers use anything they can to delay payment. And I can see them saying, you know, ICD-10, we aren't capable of, you know, something, and delaying payments for several months. Is there any way that the insurance commissioner or someone else can step in and intervene, and have they been alerted to that so that we don't have to deal with it?
Well, there are clearly, and I don't know what the prompt payment rules are in this state, but those things would fall within the prompt payment rules, right? There are laws in almost every state about prompt payment that says you got to pay within X period of time, and not being ready for ICD-10 is not a legitimate reason for not promptly paying. Right? Most of the payers I've dealt with, and a lot of different payers, including in this state, their big concern is not about how do we delay payment. Their big concern is how do we get things paid. They're very concerned, and I believe this honestly, and I used to process claims. They're very concerned that they're not going to be able to get the claims out the door, and their focus is not on holding up claims. Their focus is on trying to not hold up claims. And so, all conspiracy theories aside, I do think that that's their number one concern. Now, do they want to hang on to their more money? Yes, absolutely. But do they want to purposely delay at ICD-10? No, I haven't heard a single payer where that is even on the radar screen. Their big concern is that they're worried that they're going to have a cash flow issue or, a revenue issue. Because people will be all over that. CMS, everyone will be all over that. Yeah. Other questions? Is it time for that adult beverage of your choice? Margaritaville?
Joe, thank you very much.
You bet.
Thank you for attending, and I wish you a pleasant rest of the day.